So, in our last session, one of the biggest silly topics that we really had to dive into a little more than I was hoping to was the discussion of treatment for mainly gonorrhea versus chlamydia, where treatment was really based off of whether or not you had suspicion of gonorrhea at all, right? And even now, when I work with any of my older students, because I don't really do much private tutoring anymore, but there are some students that I was working with before I stopped who I'm continuing to help before they're, until their step one. And we were looking at some questions just over this weekend, and there were really silly questions where, they even asked questions where a patient came in. There was one question where this, I think, young girl came in and she just had chlamydia. That's all the question said. And the answer was just to treat her with azithromycin, but that was really strange to me because back when I was studying for step one from U World, almost all questions where anyone had either chlamydia or gonorrhea, the answer for treatment usually involved giving both things. Give the azithromycin for the chlamydia and give the ceftriaxone for the gonorrhea because of concurrent infection. But now, I guess because, or maybe this was a thing back then too, and maybe the questions I saw were just different or specific scenarios, but it seems that it makes sense that you wouldn't just toss azithro and ceftriaxone to everyone, simply because antibiotics are something we kind of prescribe as if they're opioids, right? It's been a weird thing for, so in other countries, I mean, I know about India, so I can say for sure that in India, you can just walk into a pharmacy and buy any and all antibiotics as you wish. There's no need for a prescription almost 100% of the time with pretty much any medication there, really. So America, if you come from there to here all of a sudden anytime and then you're like, oh, wow, I would really like some azithromycin because I feel like I need it, you can't get it. The only way you could get it is if your doctor truly deems you need it. And the way we treat patients here, if a patient comes in with what might be a cold or some kind of flu-like sickness, we let them suffer and hope that it'll just self-recover, right? Because that's the natural course it takes. And if they're not recovering and their condition is actually worsening, then we prescribe antibiotics. So we just put that patient through a lot of stress, which is pretty natural. And I guess, me and I'm sure many others are totally for, letting your body and its own immune system fight through things for sure. Yeah, a lot of people prefer not taking tablets at all. But the way we treat antibiotics, the way we give out antibiotics is very similar to the way we now give out opioids, right? Not too long ago, opioids were prescribed pretty regularly. And it's a little surreal because although I totally understand that antibiotic resistances that are developing now are becoming very problematic, and research has clearly shown that a lot of bacteria are now becoming completely resistant to a wide array of antibiotics. Unless we do this antibiotic control and ban a little more universally, it's kind of pointless, right? Because even at this point, if I wanted to, I could have any of my friends in India buy a bunch of antibiotics for me and then just ship it here. So there's really nothing truly stopping me from accessing the antibiotics I would want. And this, in my opinion, is especially bad because I don't know why we would wait to confirm, why would we even need to confirm whether or not gonococcus is suspected or ruled out? Because how can you rule anything out with 100% accuracy, specificity, and sensitivity? It's a pretty absurd thought to me. I feel like, at least with this specific scenario of getting infection with chlamydia and gonorrhea, that we shouldn't hesitate in just tossing both antibiotics into all these patients, because the long-term consequences, like pelvic inflammatory disease, and if it's a female, then ectopic pregnancy, infertility, these are, even tubal ovarian abscess, these are really problematic complications that I would never want to risk. Right? So it should generally involve giving both things, like they're mentioning here. Give ceftriaxone and doxycycline. The doxy is for the chlamydia part, and ceftriaxone is always for the gonorrhea part. So these questions are often very confusing. And I guess the lesson here is that when you do get a question, if the question has done a good job specifically telling you that you only have, the patient you have only has one of the two infections, chlamydia or gonorrhea, then specifically treat only that one infection. And that's basically what the lesson was from all the questions we did yesterday. If it's not very clear, that it's only one of them and that there is a chance it could be both of them, then you choose the answer to give both of them. The question that I did with one of my students over this weekend was a question where it was clear that the patient only had chlamydia. So you only gave the patient azithromycin, not azithro and ceftriaxone. So very, very important thing to keep in mind, because that is an easy question you don't want to get wrong. Right? It's a very easy question you definitely do not want to get wrong. Now we're moving on to everything that causes urinary tract infections. So now, of course, this whole time, as we're doing Step 2 CK studies, we've been going back and revising the systems tab of microbiology, right? The systems section of the microbiology chapter, where everything is broken down in a pretty similar design as it is being broken down right now in the Step 2 CK book. And urinary tract infections are right here, all of them. Now, when you first went through urinary tract infections, if you've done these sketchy microimages, then you remember the number one cause of UTIs was always E. coli. The number two cause and the number one cause of UTIs in sexually active women was Staph saprophyticus. And then the third leading cause of UTIs was Klebsiella, which usually occurred in patients, either male or female, who are hospitalized, right? Klebsiella, Serratia, and Klebsiella and Serratia especially are both bugs we consider to be more so nosocomial. They're only things that affect people in the hospital, because you don't really find Klebsiella everywhere. Serratia, we've all seen at some point, whether in a show on TV or in real life, is that weird stain, right? It's the weird red stain that we see around the toilet inside the bowl. If there's a toilet that's been sitting in some closed factory or something that hasn't been used in a very long time, that red stain inside is Serratia causing it. Alright, so the red pigment it creates is from there. Then there's other guys, Enterococcus, Proteus mirabilis, and Pseudomonas aeruginosa, where Pseudomonas we know really well and causes a bunch of other things. It's also nosocomial. So at the end of the day, a lot of this is going to come down to figuring out what other complications does the person have besides the UTI they have, right? Because these things don't only cause the UTI. Staph saprophyticus does actually only cause UTI, that's one thing. But then these other guys also cause other problems that you look for in the patient, and then based off of that and any other characteristics they might have given you about the bug, you can figure out what the leading issue is there. So that being said, cystitis presents with dysuria, frequency, urgency, suprapubic pain, and white blood cells, but not white blood cell casts in the urine, right? White blood cell casts is a whole different thing. Casts in general are more so related to renal problems, but this is not a renal problem. This is a cystitis. It's a urinary tract infection involving either the bladder or the bladder and or the ureters, primarily caused by ascension of microbes from the urethra to the bladder. Ascension to the kidney can result in pyelonephritis, which would present with the CAS, right? So pyelonephritis would have the fever, chills, flank pain, costovertebral angle tenderness, hematuria, and white blood cell CAS. So here, right away, in this first paragraph, you can already tell that if a question mentions there are white blood cell CAS, then you know the extent of the infection. Right? White blood cell casts now tell you that the infection has ascended all the way to the kidney. Otherwise, if you don't see the white blood cell cast, then it's still pre-renal. It hasn't really reached the kidney yet. The infection is only up to the bladder, the ureters, and that's about it. Didn't go all the way up yet. 10 times more common in women because women have shorter urethras, colonized often by fecal flora as well. And risk factors include obstruction, so anyone who has a history of kidney stones, or men with enlarged prostate, kidney surgery, catheterization, which is another big problem, and catheterization usually involves some of these nosocomial guys like Klebsiella, Serratia, or Pseudomonas. Congenital GU malformations, which could lead to vesico-ureteral reflux. Always diabetes for sure. Diabetes is also more so related to Pseudomonas aeruginosa, and pregnancy, which makes things worse, right? Because there's just too much going on there. So many case scenarios that put people at risk. Diagnostic markers are these three things we've always seen in labs, right? Whether there's leukocyte esterase, nitrite, and urease. So leukocyte esterase is basically evidence of white blood cell activity. That's all this is. So this is pretty much going to be positive in any UTI. Nitrites are for urinary nitrates being reduced by gram-negative bacteria, which mainly just points at E. coli. Alright, so E. coli is, if you see nitrate positive, then you immediately think E. coli, and that's probably the safest answer to go with at that point. Urease is more so here related to your Proteus mirabilis guy. Right? So they tell you it could be Staph saprophyticus, Proteus, or Klebsiella, but generally speaking, most questions where they'll mention this urease positivity, they're probably talking about Proteus mirabilis. Yes, Staph saprophyticus is, Staph and Klebsiella are both urease positive, sure. So is Serratia, I believe, but generally speaking, it doesn't really get tested for those guys. Here there's a little simple question. A 64-year-old man comes to the office due to 2 days of dysuria, urinary frequency, and urgency. He recently underwent a cystoscopy for evaluation of hematuria. So his symptoms look like UTI, and he also underwent a recent surgical event which did put him at risk of having this UTI. The patient has a history of hypertension, type 2 diabetes, and 30 pack years of smoking. Temperature is high, and on exam there is suprapubic tenderness on deep palpation, which suprapubic tenderness means that there's some kind of inflammation in the bladder. If you also have costal-vertebral angle tenderness, then it might have gone up the ureters. Other things that we see costal-vertebral angle tenderness alone in was usually the stones in the ureter. Urinalysis findings are as follows. So leukocyte esterase positive, which basically tells you that there are white blood cell activity in the urinary tract, so UTI. Nitrites are negative, so it's not E. coli. There's many bacteria. They tell you how much white blood cells they're seeing, and there's also some red blood cells, many. Midstream urine culture grows gram-positive cocci in chains with growth of more than 100K colony-forming units per milliliter. The organism responsible for his condition is most likely to demonstrate what else? And the answer, this is a typical step 1 type question where they ask you about characteristics of the bugs. So the answer was gamma hemolysis on blood agar. He recently underwent a genitourinary procedure and now has a UTI, so it is most likely Enterococcus. And as we were doing this question, if that didn't come to you, then you need to go revise that. Right? Enterococcus was one of those bugs that had the sketchy microimage at least mentioned do you heart trees. The do part didn't mean anything, but the U was for UTIs, the heart was for cardiac involvement from this, and then the tree was for the biliary tree. Right? So Enterococcus was involved in 3 different parts. Do you heart trees? Do you love trees? The U for urinary tract, as this guy has, especially after GU procedures, which is basically his urinary procedure of a cystoscopy, and then it causes cardiac and biliary tree infection as well. Right, so this was a very nice, straightforward question directly talking about Enterococcus. Enterococcus is another one of those guys who's also extremely resistant to most antibiotics. Nothing works. Even vancomycin doesn't work. This is the guy that you had to treat with special, expensive antibiotics, which included the tigacycline and one other medication that had another weird name to it. You know, so these guys you do need to go back and revise. You want to make sure you have them down pretty well. The only gram-negative guy was really just E. coli, right? So that was pretty straightforward. Now going to the gram-positivity aspect, you know, right here, let me see. Right here in the beginning, the first guy we see, right, this woman with the drink that has 2 straws like a ureter and the NH3 for urease positivity. This is representing Staph saprophyticus. And the guy down here is for Staph epidermidis, so there was a lot happening there as well. Let me find, and this is Enterococcus, which is about the California coccus. And you see the sign, do you heart trees, to remind you that this thing causes UTIs, biliary tract infections, and endocarditis. especially after any GI or GU procedure, just like that man in that question we just did. Right? So you treat it with tigecycline or linezolid. Right? So this is the tiger line and the police line for reminding you of the medications. Tigecycline and linezolid, both of which are pretty expensive antibiotics. So you don't really use them for anything else but this for the most part. Let me see. And I think that's really all there was to come back and look at. So we can now continue on in the first ACK book. So UTIs affect women more frequently than men, caused by the shorter urethral length, and positive E. coli cultures are obtained in about 80% of cases, the number one cause. See the mnemonic seeks PP for other pathogens. Risk factors include the presence of catheters or other urologic instrumentation, anatomic abnormalities like we said BPH, prostate enlargement, right, vesicoureteral reflux, or even previous UTIs or pyelonephritis, diabetes, recent antibiotic use, sexual intercourse, immunosuppression, pregnancy. We didn't see this one on the previous page, right, but that's another one worth remembering, because if you had recent antibiotic use for any other infection or something, then it also kills the normal flora of the vagina, and that can also lead to UTIs. Presents with dysuria, urgency, frequency, suprapubic pain, hematuria, right? But not extensive hematuria, just a little bit. The main thing being the dysuria and suprapubic pain. Right? Urgency and frequency are pretty interesting things to look for too, because generally speaking, if you have a person with, let's say, like BPH, then this really helps. Even in the question we just looked at on the 64-year-old man in the last page on the Step 1 book, you would imagine that a 64-year-old man might have BPH and actually have inability to really pee much, but this is urgency and frequency. They keep needing to and wanting to, or feel like they need to pee. So this is the opposite case scenario. Children with UTIs may actually present with bedwetting. So this is something to keep in mind, right? Because Step 2 loves making questions that are usually questions for adults, and they'll ask it about pediatric cases. Pediatrics is a more Step 2 specific kind of a topic, right? So it's a pretty big topic to worry. In Step 2, the few chapters that are specifically Step 2 and very heavily tested Step 2 are the pediatrics, obstetrics, and then your surgery and emergency medicine. Those three chapters are very much just Step 2, right? Where there's very little overlap with anything you've even looked at in Step 1. And like for instance, in obstetrics, you're going to see all those graphs of the ultrasounds and the heart monitors and stuff in neonates, and it's pretty intense stuff. So there's a lot of new things there. So here, if you ever have a kid who randomly just started bedwetting all of a sudden, and maybe they have other symptoms, recurrent fevers, really foul-smelling urine, then you know right away that the child probably has a UTI. Right? Kids get UTI simply by not being that clean. So that's all it really is. Elderly patients may present with delirium, acute confusion, and few other symptoms. So when we discussed delirium way back in Step 1, this was one of the things, right? Delirium usually occurs in elderly patients who have some underlying cause of infection. They just become very delirious. It's just something that occurs as a part of aging. The differential diagnosis includes vaginitis, STDs, urethritis, or acute urethral syndrome, and prostatitis. So we have to look up acute urethral syndrome. Seeks PP just lists out the same bugs we just looked at right now, but in a special way. So how do you diagnose someone who has a UTI? Well, diagnose is generally just by clinical symptoms. You're going to have that suprapubic pain. They'll tell you they have pain with urination, and then you're pretty much done with that. In the absence of symptoms, treatment is warranted only for kids, patients with anatomic GU tract anomalies, pregnant women, those with instrumented urinary tracts, like catheterization, or patients scheduled for GU surgery and renal transplant. And so you don't really need to treat anyone who doesn't have clinical symptoms unless there's a clear need to treat it. The best initial test is just to do a urine dipstick, right? You order the urinalysis, you're going to see the esterase, you're going to see the nitrites, you're going to see the pH and hematuria, and then you figure it out. Microscopic analysis with pyuria and bacteria are suggestive if you need to do it, but you probably don't need to do it. Generally speaking, we just treat it based off of the initial test results. There's no nitrites, then you rule out the fact that it could be E. coli, and you just give broad-spectrum antibiotics for everything else it could possibly be, which is usually just going to be the Staph saprophyticus. The most accurate test is to do a urine culture. The gold standard is to find a lot, more than 10 to the 5th colony-forming units per milliliter. All kids with suspected UTI should undergo urinalysis and culture. Very key thing. All kids. All kids with any suspicion of UTI. You just order the urinalysis and do the urine culture. Right? And then, of course, we also saw treatment is warranted only for kids, and then any of these other specific adult scenarios. So you have to specially treat kids in a different manner. Use catheterization to obtain the sample in patients who are not toilet trained to avoid contamination. All right. Treatment. So there's a difference now between uncomplicated UTI versus complicated UTI, case 1 and case 2. The uncomplicated UTI, you just treat on an outpatient basis with PO trimethoprim or fluoroquinolone for 3 days. You could also use nitrofurantoin for 5 days. Maybe they have an allergy to sulfa drugs, so you don't want to give TMP-SMX, right? The use of fluoroquinolone should be reserved for severe symptoms in light of resistance and MRSA selection and risk for C. difficile infection. So very dangerous to try to give any of these two medications. So generally speaking, giving nitrofurantoin usually is the safer answer choice, right? Because many times patients who haven't really taken much antibiotics their entire life don't know that they have a sulfa allergy. So you don't really need to find out now. And fluoroquinolones have a lot of issues of their own, so just give nitrofurantoin. 5-day nitrofurantoin packet, they take it home, they eat it, they'll be fine. They'll recover. Now, if the UTI is complicated, so they call it complicated because there's other things happening. So a complicated UTI could be due to urinary obstruction, UTIs in men. A UTI in a man is always considered a complicated UTI. Renal transplant, catheters, and instrumentation. Administer the same antibiotics as above, but for a longer period. So thank God, right? Nothing intense here. It's not, although they're calling it complicated, the treatment is just the same shit, but for pretty much triple the amount of time. So instead of giving for 5 days, you would send them home for 15 days or 14 days, and they're done. All right. For pregnant patients, treat asymptomatic bacteriuria or symptomatic UTIs with, once again, nitrofurantoin. Or you could use oral cephalosporin or amoxicillin for 3 to 7 days. Avoid fluoroquinolones, trimethoprim, and tetracyclines. Right? So in my general rule of thumb, I just find it safe to say don't use it anywhere. Right? You don't need to use it in this first case scenario either. It seems nitrofurantoin is the answer to go with. Right? Same antibiotic as above. So nitrofurantoin 5 days, nitrofurantoin for 14 days. Same thing here, nitrofurantoin for 3 to 7 days. Right? Confirm clearance with the post-treatment urine culture, and things should be okay now. Right, so far for all 3 of these cases, we're just using nitrofurantoin. Urosepsis. Patients with urosepsis should be hospitalized and initially treated with IV antibiotics. Consider broader coverage to include resistant GNRs or Enterococcus. Remember, Enterococcus wasn't affected by anything. For the most part, Enterococcus really just require linezolid or the tigecycline, so you would have to wait and see. You would wait for the cultures to come tell you it is Enterococcus. But urosepsis is septic, so it's becoming a bigger problem now. Prophylactic antibiotics may be given to women with uncomplicated recurrent UTIs. Check for prostatitis in men. Methenamine can also be used, which is converted to formaldehyde by acidic urine. Right, so methenamine is just a test to do. So what's up with this prostatitis thing? Well, prostatitis can be differentiated from a UTI by the prostate tenderness on exam. Urethral catheterization and prostate massage are highly contraindicated because they increase the likelihood of bacteremia. Treat with TMP-SMX or ciprofloxacin for 6 weeks. That's the case scenario mainly for the prostatitis aspect. Right. So a couple things happening here, and trust me, although it might look like it's not that bad and straightforward, and even though I've tried my best to kind of simplify it by just telling you to use nitrofurantoin, questions about UTI treatment can get pretty weird. Right? Pretty weird. Because questions are never going to be, oh look, this patient came in, you did the order of your analysis and you saw some white blood cells and you didn't see any nitrites and it looks like there's a little bit of high pH, so you figured out it's Proteus. then they're going to be like, okay, what's the next best step? And they might not really have nitrofurantoin as an answer choice, and then you get a little thrown off. So you have to be a little careful about that kind of stuff. You can always go back to your step 1 stuff and check the treatment for each one of these. I would recommend, and I'm going to do this after this session, to put the specific antibiotic used for each one right here. Since they've nicely listed them all out anyway, if there is any specific antibiotic each one is treated with, list it out over here. Go do the little bit of research, find the answers, and list it out over here. And then I'll do it after this session, and I'll show it to you guys tomorrow. And that way you have things in the back of your mind, so it rings a bell if you see a different answer choice other than nitrofurantoin. Because picking answer choices of antibiotics is always like a stupid, silly question, because they're going to try to trick you with like other side effects of those antibiotics. So as you're listing out the antibiotics that you would use for these specific guys, find a way to drill it into yourself. Right? Maybe Sketchy Micro has a specific thing in the picture. Just memorize that thing, not the whole picture if you're not a fan. And then you also have to do another thing. For each of those antibiotics, you need to go check for the biggest side effect it can cause. Right, the biggest side effect it can possibly cause, because if you have, let's say there's an antibiotic here that causes torsades, right, QT interval prolongation, you wouldn't want to give that antibiotic to a patient who the question might have told you has heart problems to begin with. So that's the kind of stuff that makes simple questions a little more intense. And I mean, I'm with it. It's okay because it's pretty real. You will get patients who have UTIs and have a heart problem and other contraindications, so you don't want to treat everyone with the same thing. Next thing is the pyelonephritis. So now, nearly 85% of community-acquired cases of pyelonephritis result from the same pathogen that caused the cystitis. It just ascended further up. Cystitis and pyelonephritis have similar risk factors. Signs and symptoms are also similar to those of cystitis, but show evidence of upper urinary tract disease, such as flank or costovertebral tenderness, fever and chills, nausea, and even vomiting can occur. Right? Because vomiting, remember, also occurs with the same thing where you have a patient with a stone going down the ureter. That inflammation and that bother that you get from the ureters having some kind of issue can actually spark vomiting. It's a very weird reflex, right? But it just happens. So diagnosis, again, same kind of thing. UA in culture, CBC with just leukocytosis. Imaging won't really be a thing. You don't need to do imaging. Imaging is usually a thing you do when you think of like stones and stuff, right? But in general, imaging is not necessary. Patients who relapse or do not respond to therapy within 3 days should be evaluated by an ultrasound or CT to see if there's an obstruction, abscess, or some other issue. But you don't really do imaging initially at all. There's no need to. Right? Pyelonephritis is the most common serious medical complication of pregnancy. Among patients with untreated bacteremia, 20-30% will develop pyelonephritis. For mild cases, treatment-wise, you just treat an outpatient for 7 to 14 days, send them home with some fluoroquinolones. That's the best initial treatment here. But of course, if the patient is pregnant, the fluoroquinolone is not the way to go. And this key fact does make it seem like most questions about pyelonephritis are either going to be pregnant women or the typical younger teenager. The younger teenager, you could do the fluoroquinolones, encourage more water drinking, and monitor closely. Admit and administer IV antibiotics to patients who have serious medical complications or systemic symptoms, are pregnant, present with severe nausea and vomiting, or have suspected bacteremia. Fluoroquinolones, 3rd or 4th generation cephalosporins, beta-lactam inhibitors, carbapenem can be used depending on disease severity. Abscesses that are more than 3 centimeters should be drained and cultured, which is going to be an answer choice. Right? What's the next best step? They'll tell you that you had to do. So the whole question will start off with someone who's got a pyelonephritis issue. You gave them some antibiotics, it didn't work out. 3 days later, they came back, they're still sick. Now you did the CT, you found the abscess, and the abscess is more than 3 centimeters. What's the next best step? The answer is not to pick another antibiotic or admit them and give IV antibiotics, none of that, no. As soon as they show you that the abscess is big, the next best step, drain and culture it. You need to know exactly what that abscess-causing bug is, and then administer IV antibiotics for that specific bug, which is again why you need to go back and look up how to treat each one of them, write that down, and write down what each of those treatments' biggest side effect is. So I'll do that after this session, and we'll talk about this tomorrow. All right. Let's take a look at this question over here. 4-year-old girl is brought to the clinic. So this is a little girl, 4-year-old girl. Clinic due to swelling on the neck. Okay. The mom first felt a few lumps on the patient's neck 2 days ago while brushing her hair. Size has not changed. No recent fever, cough, rhinorrhea, or sore throat. Preschool. Hasn't traveled. Vitals are okay. I mean, I wouldn't really highlight the blood pressure here either because it's a 4-year-old girl, so you don't really expect typical and normal levels of blood pressure. Physical exam shows anterior cervical lymph nodes that are bilateral. So remember, this is pretty big. We just finished doing HEMONC, right? If you had a cervical lymph nodes on one side, then you would start thinking it could be lymphoma, right? Like Hodgkin lymphoma. But this is cervical lymph nodes that are very small on both sides, so maybe she had some kind of bit of an infection, but nothing crazy so far because she's doing okay. She doesn't really have any symptoms per se. The oropharynx is clear, cardiopulmonary exam is normal, no hepatosplenomegaly, everything is unremarkable. What is the best next step in her management? So you see, when I was reading this question, all I really highlighted was her age and the fact that everything's unremarkable. And I didn't do this before sitting down with you guys right now. I'm always highlighting things the way I would highlight it on the exam so I can show you guys what I'm focusing on, right? It's very much possible that other students who would read the same question would highlight a lot more. They would highlight that there was a swelling on the neck, right? That there were few lumps. The size has not changed, so they would highlight that, right? Then, of course, no, nothing's wrong. And then they would highlight the physical exam aspect. What did they see, right? And they might highlight the bilateral part, but then everything else is no, nothing happened. And now there's a lot more here to convince you that something may be wrong. Because now you're focusing on the swelling, the lumps, right? Physical exam having it bilaterally, something must be wrong. And then once you focus on the new things I just highlighted, you would pick to order a CBC. But there was no need for that, right? There was no need for that. And those are the two kinds of students that took this question, majority, right? 90% of people. 60% chose observation only because all they focused on was the fact that the girl has nothing wrong. There's nothing wrong. So there's no reason to do anything right now. I don't know if this is what we would actually do in real life practice. I mean, real life practice would have more involved, right? In a real world practice, if you're seeing this girl for the first time as your patient, you would order a shit ton of stuff. But if this girl is one of your regular pediatric patients, then you would have some other labs on her and other things on her already. Maybe you wouldn't order things. So the real world application of these questions are becoming very weird to me lately after having looked at so many questions, right? Because this is not seeming very real world at all. But in terms of the video game we play with questions, right? The game of STEP, I can see clearly there's nothing wrong, so I'm just going to do observation. That's the best thing to do here. Now, 30% chose to order a CBC. Not the most expensive thing in the world, not the most harmful thing to order. There really isn't a problem with ordering a CBC here. You can. Why would you order a CBC? Because maybe you think she has Hodgkin lymphoma. Maybe you think that something's wrong and, whatever's happening will become more evident. But that was the wrong answer. And it comes from focusing some of the other things I highlighted. Right? Palpable peripheral lymph nodes are common in children and young adults. You would not know this unless you're a pediatrics physician. Reassuring features include palpation that reveals small, soft, mobile nodes that are localized to one area. On the other hand, any abnormal lymph node findings, including those related to size, quality, location, and progression, signify lymphadenopathy. But this was not really lymphadenopathy. Malignant lymph nodes tend to be firm, immobile, and large. Systemic findings are often present. Generalized lymphadenopathy is also worrisome and suggests malignancy or infection with CMV, even infectious mononucleosis in more grown-up girls. Although localized lymph nodes are typically benign, palpable supraclavicular lymph nodes should be considered pathologic until proved otherwise because they are associated with GITGU and pulmonary malignancies. So even though there's a risk of these things possibly being associated with malignancies, we're not going to do anything. We're just going to do observation only because this is how we practice medicine. Right? Don't order the CBC just yet. It's kind of silly to me. I'm not going to lie. I feel like this palpable peripheral lymph node aspect, so we're literally depending on something very vague, right? My ability to palpate a lymph node and measure it simply based on palpation, it's kind of strange, right? This child has normal cervical lymph nodes and no systemic findings, so management should consist of reassurance and observation. Most palpable lymph nodes are benign and regress within several weeks. Only abnormal features require a CBC. So since she didn't have any abnormalities, she wasn't having fatigue, not even fatigue, nothing, weight loss, no symptoms whatsoever. So if you get a question, and this is very common on step 2, if you get a question where there's absolutely nothing fucking wrong with the patient at all, don't do anything. Just don't do anything at all. Don't order any tests, don't order anything, just send them home. Right? That's basically what your world is taught, and that's also what first aid is agreeing with. First aid also mentions the same kinds of things. Right? So that's basically it for that stuff. Now, at this point, the most important thing to do would be to go back to step 1 microbiology, check out the various bugs we just looked at in terms of urinary tract infections, and then write out what they cause. All right, and that's it. That's it for today. Tomorrow we're going to wrap up the rest of this, right? So we just have hematologic infections left. These are pretty straightforward, nothing crazy with them. We'll rush through them. These are all stuff that we've already looked at. Like even this image should ring a bell for the pharyngitis we've looked at in step 1. We'll look at some other things, and then we'll be done with that chapter. We'll be done with the fever section. Nothing insane there either. All the typical tick-borne infections we looked at in step 1. Nothing brand new here either. And we'll basically be done when we wrap up miscellaneous infections. This is a bigger chapter with the infective endocarditis, because now we're going to be looking at involvement of things from cardiovascular as well. Infective endocarditis was a huge infection topic in step 1 as well. And so we'll have to do all of that, and my goal this week is definitely to finish up all of ID so we can move on to the next thing, which is going to be I'm going to skip over MSK, because MSK is also, once again, just stuff you study on your own. There's nothing there for me to teach per se or make easier, and we're going to jump to the next big thing of neurology. Alright, so that's it for now. One thing I did want to look at was there's a question right here. Where's this guy? This one. No, it's a bite. There's one last question that I know was related to stuff we just did. I literally just saw it. That's chikungunya. This one. Okay, now we're good. Alright, so we'll continue on when we see each other tomorrow morning now. Alright, so enjoy the rest of your day, and then I'll see you guys tomorrow.